Disorders of Consciousness program at Spaulding Rehabilitation Hospital in Boston, and I'm a professor of physical medicine and rehabilitation at Harvard Medical School. I've been invited to speak to you today about neurostimulation in disorders of consciousness. Here are my disclosures. So the presentation today has three parts. I'm going to begin with a review of definitions and diagnostic criteria, then discuss the importance of a conceptual framework to inform our approach to treatment of this population, and then review 4 neuromodulatory treatments that have been assessed under controlled conditions. So let's start first with just a look at the landscape. So these are the 4 major disorders of consciousness. Classically defined, coma is a state of complete unconsciousness in which the eyes remain continuously closed. That's the defining feature. There is no arousal because the arousal system is offline. In the vegetative state, the eyes open spontaneously because the arousal system is back online, but there's still no behavioral evidence of awareness of self or environment. And we have, of course, the subconditions, the persistent vegetative state, which is simply a vegetative state that has lasted for 4 weeks, and now the chronic vegetative state, which we define as a vegetative state that lasts for at least 12 months after traumatic brain injury and at least 3 months after non-traumatic brain injury. The minimally conscious state is a severe condition of severely altered consciousness, but here we have minimal and definitive evidence of behavioral signs of self or environmental awareness. We have now 2 subdivisions, MCS plus, which means that there are signs of conscious awareness that include evidence of preservation of the language system. So it might be expressive language or receptive language like command following. In MCS minus, there are behavioral signs associated with consciousness that do not include evidence of preserved language function. And then the post-traumatic confusional state. In this condition, patients typically have normal arousal. They're clear evidence of awareness of self or environment, but there's global impairment of cognition, typically characterized by arousal fluctuation, attentional problems, basically inability to focus attention. There may be restlessness or the opposite, apathy, and then sleep-wake cycles are typically disturbed. So these are the 4 major disorders of consciousness. And this table shows the distinguishing features of these conditions represented by the gray boxes. So starting with coma, again, the absence of any eye opening. In the vegetative state, we have eye opening, but no behavioral signs of consciousness. Progressing to MCS minus, these are the 6 behaviors that are associated with consciousness, but none of them are indicative of language preservation. But in MCS plus, we have at least one of these 5 behaviors, which do suggest preservation of language. And then the 4 cardinal features of post-traumatic confusional state. In my view, treatment interventions should always be guided by a conceptual framework. The Meso circuit model, which was described by Nico Schiff at Cornell, provides such a framework for understanding potential mechanisms of action for various therapeutic interventions, as well as the underlying neurobiological perturbations that contribute to impaired consciousness. The model is premised on the notion that in normal consciousness, the central thalamus is regulated by a bidirectional cortical thalamic feedback loop that is driven by the prefrontal cortex typically, but also an inhibitory pathway that runs through the striatum. And that pathway is further regulated by corticostriatal and thalamocortical inputs through the central thalamus. A key node, though, is the central thalamus. It broadly activates the mesial frontal regions of the cortex as well as dorsolateral association areas. So the mesial frontal regions, as we know, are very important for drive function, so initiating behavior, behavioral persistence. And then, of course, the dorsolateral association cortices are important for attentional control and executive functions. In the setting of severe brain injury, there is deafferentation and loss of neurons from the central thalamus. And as a result, the central thalamus fails to adequately drive the striatum. And the striatum is important because it normally inhibits neurons in the globus pallidus, which is an inhibitory structure. So what essentially happens is that we get tonic firing or tonic activation of the globus pallidus. And again, because it is inhibiting function, it's putting the brakes essentially on the central thalamus, which then does not drive or activate downstream cortical targets. So this is basically a way to think about points points at which we can, or nodes at which we can intervene. And we're going to talk about that for the rest of the talk. And you see here in the blue boxes some of the interventions that I'll be talking about and where they're thought to be active. The mesocircuit model may explain mechanisms of action for several of the treatments that we have some promising results for at this point in promoting recovery of consciousness and function in patients with severe brain injury. So for example, there is evidence in panel A here that amantadine, administration of amantadine hydrochloride, increases frontoparietal metabolism. Zolpidem, panel B, directly and indirectly excites the frontal striatal circuit. In panel C, transcranial direct current stimulation may increase activation of partially preserved prefrontal cortex. Repetitive transcranial magnetic stimulation induces this global increase in cortical oscillations across the whole primary motor cortex. A new intervention called low-intensity focused ultrasound pulse, or LIFE-UP, has been shown to non-invasively stimulate the thalamus, which again is critical because then the thalamus can activate downstream cortical fields. And even some evidence that direct stimulation of the vagal nerve may increase cortical connectivity. And then in deep brain stimulation, which targets again the central thalamus, there is evidence that we can activate these preserved but downregulated downstream cortical targets, which we'll again talk about shortly. In 2018, the American Academy of Neurology, the American Congress of Rehabilitation Medicine, and the National Institute on Disability Independent Living and Rehabilitation Research published updated practice guidelines for clinical management of patients with disorders of consciousness. The final recommendations were based on a systematic review of 371 papers that were published over a 6-year period between 2012 and 2017. Of 129 treatment papers reviewed, 28 qualified for the review, but only 2 Class 1 studies and 1 Class 3 study, were methodologically rigorous enough to drive treatment recommendations. The only treatment for which there was sufficient evidence to make a recommendation was amantadine hydrochloride, as noted here. Clinicians care for patients with traumatic, and by the way, this was specifically for traumatic brain injury, so patients with traumatic vegetative and minimally conscious state, who are between 4 and 16 weeks post-injury, should receive amantadine at 100 to 200 milligrams a day to promote functional recovery, or actually hasten functional recovery and reduce degree of disability, as long as there are no medical contraindications. So what is the evidence for that? So this is, I'll give a brief review of the study. Participants were adults with traumatic brain injury that resulted in either vegetative or minimally conscious state. All were between 4 and 16 weeks post-injury. And you see on this slide, the slope of recovery, excuse me, over the course of the 4 weeks that the patients were actively treated. And then the active treatment period was followed by a 2-week washout. So overall, it was a 6-week observation period shown on the x-axis. On the y-axis, we have the disability rating scale. And these scores go from 0, indicating no disability at all, goes all the way up to 30, meaning death. And disorders of consciousness are typically scores above 20. So at the beginning, at baseline, you can see that the two groups, the blue group is the placebo group, and the red group is the amantadine group, were no different on the DRS when the trial started. But very quickly, within a week of beginning this trial, the amantadine group started to improve more rapidly. So by the end of 4 weeks, there was clear separation in their DRS scores in favor of the amantadine group. And then a sort of unexpected finding, when we stopped the amantadine to begin the washout, the amantadine rate of recovery leveled off very quickly, so much so that the placebo group was actually recovering at a faster rate than the group that had previously been on amantadine. So by the end of the 6 weeks, or end of the 2-week washout, there was again no difference between the two groups. If we look at behavioral recovery in the group that was treated with amantadine, shown in blue here, and the group that was given placebo, you can see that across all behaviors except for speech, except for intelligible behavior, intelligible verbalization, the amantadine, there are more individuals who recovered these behaviors in the amantadine treated group than in the placebo treated group. So another line of evidence that amantadine is indeed effective in promoting or accelerating rate of recovery. Moving on to zolpidem, or Ambien, the brand name here, at least in the US. Zolpidem is a sedative hypnotic agent that's used to treat insomnia, but we know now may have paradoxical effects in patients with disorders of consciousness, meaning that these individuals become more responsive following administration of zolpidem. Breffel-Corbone and colleagues found a drug-induced activation of the anterior cingulate and the orbital frontal cortices in response to zolpidem. So you see the difference between the metabolic profiles on placebo, and then the bottom panel, the increased activation following dose of zolpidem in the orbital frontal cortices and in the cingulate. John White and colleagues in Philadelphia completed a multi-center placebo-controlled double-blind single crossover trial that included 83 participants. This was a multi-center study who were all in vegetative and minimally conscious state between 5 and 99 months post-injury. So subacute to post-acute population. And as evident here, approximately 5% of participants were characterized as responders based on changes in their scores on the coma recovery scale revised when they were compared to baseline. The figures on the right here represent 4 patients, and it's showing their scores on the CRSR over a 3-hour period during which serial assessment was conducted with the coma recovery scale. So what you can see is an inflection in this score on the CRSR following within about an hour of administering the dose of zolpidem. And then over the course of the next 2 hours, there's this leveling off and then a decline back to baseline. But again, the key point here is that only 4 out of 83, or 5% of individuals, were responders. And I think others have sort of replicated this now anecdotally. This is a small number of people. But the point is that this is an easy drug to use, in part because it's safe and it has a quick on-off effect that is pretty easily discerned. Transcranial direct current stimulation appears to increase or decrease neuronal excitability, synaptic strength, as well as cerebral blood flow by modulating NMDA and dopaminergic pathways, depending on, the facilitation or inhibition depends on the stimulation configuration. So this study is one of the better studies on TDCS completed by Aurora Thibault. This was a double-blinded, sham-controlled, randomized crossover study, and they tested the effectiveness of a single 20-minute session of anodal TDCS that was applied to the left dorsolateral prefrontal cortex in patients who were at least 1 week post-injury and diagnosed with either vegetative state or minimally conscious state. And they found that 43 participants in the 43% of participants in the minimally conscious state showed at least one behavioral sign of consciousness not previously observed after they received the TDCS. And they also reported 8% of participants who were in vegetative state for less than 3 months demonstrated command following or visual pursuit after receiving TDCS. They also showed there was increased functional connectivity in the default mode network, as well as the bilateral frontal parietal cortices as the result of this episode of TDCS treatment. So at least some leading evidence that there are transient changes, improvements in terms of behavioral responsiveness based on administration of TDCS. And again, this was only a single session. Moving on to deep brain stimulation. In 2007, our group published the first report of central thalamic deep brain stimulation administered to a patient in chronic minimally conscious state. This is chronic traumatic minimally conscious state. So this individual was 6.5 years post-injury following an assault that resulted in severe bifrontal and bilateral thalamic injury. At the time of enrollment, he was living in a nursing home. He occasionally followed some simple commands, was totally nonverbal, well, not totally nonverbal, was largely nonverbal. He had been observed on rare occasion to say a single word, and he could not communicate in a reliable manner. So he was enrolled in the trial, and what you see here is this subject's performance on 3 subscales of the CRSR, the oral motor verbal subscale, the arousal subscale, and the motor subscale. On the left here are the individual items on those 3 subscales. And what we're looking at are the course of changes in his CRSR performance over the 3 phases of the study. So the dots indicating his score on these subscales. So first we have the baseline period, DBS off. There was, the stimulator was turned off. And then surgery was performed. So that's the middle panel. And then what you see here is depicted by the green arrows is this near immediate increase in his performance on CRS across all 3 of these subscales once the stimulator was turned on. So you see here in the most compelling illustration that on the oral motor verbal subscale, he was getting a score of 2 consistently at baseline. So a 2 on the CRSR means that there's no intelligible speech. There's sound, person can vocalize, but no intelligible speech. And then after the DBS was turned on, you see many instances of intelligible speech. It was possible to prompt him to speak much more readily after the stimulator was turned on. And we saw similar increases in his ability to focus his attention and then also to use objects in a functional manner, like a cup or a comb, for example, that he was not doing previous to the DBS. I will mention that we are now finishing a second clinical trial of central thalamic DBS that targeted patients who initially sustained severe traumatic brain injury, but improved to the point where they are functionally independent, so they can take care of themselves at home, but unable to return to academic study or competitive employment. So this is a small trial, a 6-subject trial, and those results will likely be published next year. So we will have more information to report on DBS for severe TBI soon. So to sort of just summarize, while numerous treatments are currently used to promote recovery in patients with disorders of consciousness, there is only one treatment at this point, amantadine hydrochloride, that has sufficient evidence to support its routine use in clinical practice. The development of effective treatments, and clearly we need a lot more work in this area with only one effective treatment that's been demonstrated. Our work should be guided by an understanding of the neurobiological substrate mediating consciousness and cognition. And I think the best model that we have at this point that has been tested in both animals and in humans is the Meso circuit model, again, described by Schiff and colleagues. The good news is that there is increasing evidence that both invasive and non-invasive neuromodulatory interventions, like the ones we just reviewed, can facilitate post-acute cognitive and behavioral recovery. But it's very clear that we need both pragmatic and randomized control trials to move this field forward and to accelerate the pace of development of effective new treatments. So I thank you for your interest. I want to just acknowledge my collaborators on all of this work and look forward to speaking with you further during the panel discussion.